Now this is very important. So what you can actually try to put flush osteal stenting. Now, some degree of osteal miss or main branch protrusion. So I have already discussed. So it depends on the angle. So unless it's a almost 90-degree angle, you cannot actually get a perfect position. Either it will be in the left vein or you will miss the ostium. So that is the important issue. And number two is the spiky carina. In the previous speaker, he have in detailed discussion of the spiky carina. So in a spiky carina, you don't try to put a stent in the ostium. You just cross over the stent. Otherwise, there is significant or malignant carinal shift and the patient having symptom travel. So this is the main issue. You can see the second position. So this is a large ostium, more than around 90 degrees. In such cases, you can try, though it is very difficult. So this is one of my cases. So she has a ACS symptom and LAD and the circumflex ostium were disease. So you can appreciate the circumflex ostium having significant disease from the very proximal ostium. And after fixing the LAD, I plan to do a circumflex flushing stenting. There is just keeping the stent in the LAD circumflex ostium. So after pre-dilatation, I put a stent precisely in the circumflex ostium. There was not significant movement of the stent, so I was fortunate in that setting. So I can able to place the stent perfectly in the ostium. So this was the result, and after post dilatation, so this was the result, and without significant protrusion or any main branch or LAD ostial compromise. So this was the case. Now I got the opportunity to do a check angio 6 months later when the patient actually came with a CHB and syncope. So 6 months. So I did a check angio during the permanent pacemaker implantation, and I found that the circumflex ostium stent and the LAD stent is perfectly patent. So this was you can tell it's a short-term follow-up, but it's a 6-month follow-up of this flushing of this flush stenting. Now another technique is the inverted provisional stenting, as my previous speaker told. Is directly go for the left vein to LAD stenting. So here you can also go inverted provisional stenting. That is, you can go from the left vein to circumflex and making the LAD as a side branch. And I think this should be the default approach and more predictable approach. So it is more predictable. So this is another case. You can see there is a mild left vein plaque, and with the LAD is healthy, and circumflex proximal part starting from the ostium having significant disease. So after pre-dilatation of the ostium, you put a stent from the left vein to your LAD, left vein to circumflex, and after POT and post dilatation and rewiring, this was the ultimate result, and the patient is doing good in the follow-up. So this is by default. I think if you have to do a circumflex ostial stenting with a narrow angle, so this is basically you can do the case like that. So inverted crosswise stenting. Now this is third scenario which can happen. So if you have done a left vein bifurcation by the two-stent strategy. So this is a LAD. Is a Medina 111 classified bifurcation, distal bifurcation lesion, and we did a two-stent strategy, and after putting the stents and crushing, putting the main vessel stent, and final pot kissing, you have achieved a good result. This is the final result you have achieved. Now there is hardly any problem in the final result, and also I was also showing a good result. But what happens after 8 months? The circumflex and the left vein to LAD stent is almost normal. Again, the problem in the circumflex ostium. So circumflex ostium having the significant disease, and this is having a stent also placed at the present moment. So putting another stent in the circumflex will should not be a solution here. So in these cases, drug coated balloon is a choice basically in these cases. So you pre-dilate either a scoring balloon or cutting balloon thoroughly, and then put a DCB drug-eluting balloon and do a final kissing and just come out. So this is another strategy of doing a circumflex ostial disease. So this is IVAS and showing acceptable result. So this is my I have a final case. So this is another stenting. So you can appreciate the mid part of the LAD is tight lesion, but the lesion has been started from the very proximal part of the LAD ostium. So the stent was placed in the, tried to place in the ostium. So you can see the position of the stent. This is the final position of the stent. And you can see the acute result is very good, no doubt. But if you see carefully, there are a few starts they are protruded in the circumflex ostium or left main. So this is the problem you cannot provide. You cannot avoid this. You cannot avoid this. How much you are very precise. There is some movement. You cannot actually. You are not God or you are not a robot. You just fixing the place just at the ostium. So it's very difficult to put the place correctly at the ostium. So what happened again after 2 years? The patient having patent the LAD stent. There is no problem in the LAD stent, but again the burden goes on the circumflex. So that is why I am telling. Circumflex is a notorious vessel. The ostium is a notorious part in doing the left main bifurcation. So again, the very bad condition of the circumflex. Now you have no option putting a stent, and in this case, the culotic technique is a very important to bail out. As a bailout technique, you just dilate it, put a stent from the left main to circumflex, and then recrossing in the LAD, and after doing a final pot, final kissing and final pot, you can get a good result. So this is the final result. I think this is acceptable result. So in nutshell, so to conclude my talk, so LCX ostium, again I am telling it is basically Achilles heel in the left main bifurcation, doing a left main bifurcation. This is this crux. So we always feel that what will be the fate of the circumflex ostium, what strategy we are taking. So isolated left circumflex ostium is a very difficult subset to treat because we are doing the circumflex, and nobody wants that after doing a side branch or circumflex, the main branch will be compromised. There is a LAD will be compromised. So this is the main concern. So our threshold should be very high for the coronary intervention of a circumflex ostium. And physiologic assessment is very important. Only seeing the angiogram, it's a tight lesion. I don't prefer to do a case, particularly in a chronic stable angina. You must show in a physiological imaging, physiological way, there is a objective evidence of significant myocardium ischemia is there. Then you will only treat the circumflex ostium. And if angle is conducive, that is, if angle is 90 degree, then yes, if there is no plaque in the your left main or distal left main on the LAD ostium with a 90 degree conducive good angle, you can try a flush position, flush nailing of the stent in the circumflex ostium. Otherwise, don't try to put the stent in the perfectly in the ostium. Definitely, it will actually miss. Either it will miss the ostium or it will go in the left main, and later it will compromise the main vessel LAD. So inverted provisional technique should be the default choice. This is my opinion, particularly when the angle is not conducive, is a narrower angle. And yes, imaging not always possible in our country. Not all lab having your IVAS or OCT. So, but imaging should be done because, as my previous speaker was also stressing the fact that imaging can show that it's a isolated circumflex or isolated LAD ostium. They are basically not possible. There's some plaque distribution in the distal left main or LAD or side branch also. And DCB is now an emerging option, particularly if there's already a stent placed in the circumflex, particularly in two-stent bifurcation technique. Some operators are doing actually the isolated circumflex de novo lesions, doing a good cutting balloon and then putting a circumflex, but there's no significant data. So this is not a platform to promote this concept of doing a DCB in the your circumflex ostium isolated lesion. But yes, DCB is emerging, and I don't know after 2 to 3 years if I am to again give the talk, there maybe DCB can be an option there. And this is my conclusion slide. Thank you very much for your patient hearing.